So I think it's a big, that's a very important question. It's important to distinguish between PD-L1 staining, tumor mutational burden, and microsatellite instability. Sometimes it's kind of confusing for people for both. Can you kind of, I know you've talked about, but can you parse them out or this three? What is the PD-L1 staining? What is a tumor mutational burden per se? And what is microsatellite unstable tumors, and how are they different?
Sure. So PD-L1 staining is primarily identifying the intensity and the proportion of cells, both tumor cells as well as the lymphocytes, in the actual tumor biopsy specimen. So that is a numerical value. That's
like an immunohistochemistry, you stain it and you look at how much brown you see, basically.
The mutational burden is detected primarily by next generation sequencing. So that is the actual mutational load, or the number of mutations seen within a coding segment of the genome. And so again, the tumors that have high mutational burden, such as melanoma, CSCC, MSI high cancers, those tend to respond better. Contrast that with certain pediatric tumors or low-grade tumors, or even uveal melanoma, the other disease that I treat. They really don't have a high degree of mutations at all. So that can, several tests that are directly, again, on tumor tissue identify mutational burden. Microsatellite instability, I think you're more of the expert than I am. And again, starting with colorectal cancer, you know, specifically looking at microsatellite stability, instability genes, and to, again, from an immunohistochemical standpoint, can be done, or can also be done on next generation sequencing. CD8 density, again, that's primarily looking at the tumor itself and looking at, through immunofluorescence assays, understanding what is the percentage of CD8 positive cells right at the tumor interface. And several publications have now highlighted there's such a vast difference between tumors in this regard. Some tumors, such as melanoma, it's almost exclusively on the tumor cell, the PD-L1 staining. In some tumors, it's literally at the interface of the tumor and the lymphocytes. And you know, in some gastric cancers, we actually see them more on the lymphocytes alone and not on the tumor at all. And I think we're still trying to scratch the surface, or maybe we're going down the wrong biomarker. I don't know the answer to that, and time will tell us.
And maybe the different biomarkers for different disease. So for immune checkpoint inhibitors, CSCC could have a different biomarker than gastric, than lung, and such. Now, we talked about response in melanoma. You said it was higher in treatment naive. What were the response rates seen with immune checkpoint inhibitors in CSCC?
So in the EMPOWER study, and this was done in two parts, as I mentioned earlier. You had a phase 1 part and a phase 2 part. And what was reported in the New England Journal publication was a compilation from both of those parts. In the phase 1 part, it was 26 patients. In the phase 2 part, which was reported, was specifically for metastatic CSCC. The locally advanced cohort in the advanced, or the phase 2 portion, had not yet reached maturity in terms of data. So when one collates this together, we had a total of 85 patients on that clinical trial at the time of reporting. The vast majority were male, most of them with good functional status, and as we mentioned, many of them had already been heavily pretreated either with chemotherapy and or radiotherapy.
I think then somewhere in the 90s, right? Somewhere fairly, fairly older.
When you look at both modalities, yes, you're absolutely correct. And of course, surgery had been part of their armamentarium that had already been received previously. In terms of when one parses it out in terms of the phase 1 portion, the response rates were approximately 50%. So half the patients treated with cemiplimab
had shrinkage of the tumor.
Had shrinkage of the tumor as defined by RECIST 1.1 criteria, which is greater than 30% decrease in the sum of the largest dimensions for the measurable tumors. And that's quite remarkable. 50% actual response rate and about a 20% stable disease rate. And as you know very well with solid tumor oncology, stable disease is important. We are trying to keep the disease under control. So the entire disease control rate was almost 70%. With metastatic disease, slightly less, it was 47% response rate. So for all practical purposes, that's about half the patients are responding. But what's also more important, particularly with immunotherapy, is durability of response. You know, how long can we keep the disease under control?
That means just not a quick response and then it kind of grows.
Right.
There's durability of response.
That is correct. So greater than 50, I think if I recall my numbers correctly, it was about 57% of patients had a response that was durable, at least based on definitions of the trial, which was a response lasting for at least 15 weeks. These data were very recently updated at the European Society for Medical Oncology, where again in the phase 1 portion, now the median survival as of January 2018 had reached approximately 12 months. and the durability of response is still standing out and still being seen. So my hope is that this durability will continue with further follow-up on these patients, which I think is critically important. What it doesn't answer is how long should you treat these patients. With melanoma, we are now recognizing, depth of response is important, and patients who achieve a complete response and have had a defined period of treatment, we may be able to consider stopping therapy in those patients. Whether the same applies for CSCC, I think is still too early to tell. But in the phase 1 portion of the trial, the treatment was continued for 48 weeks, with cemiplimab being delivered every 3 weeks. And in the phase 2 portion of the trial, it was the option was to go up to 96 weeks or progression or the development of toxicity.
So 1 to 2 years.
Correct.
I'm trying to get my weeks right here.
Yes, that is correct. Yeah.
So 1 year, and then you could go up to 2 years in the phase 2?
Correct.
Okay.
That is correct.
And so the patients who, so after 2 years, are there any patients who stop therapy now, or it's just too early to tell?
I think it's too early to tell. I have not seen that data yet, but I'm sure that will be coming out very soon. Because again, this is in some ways, the first of its kind study, the most mature study in CSCC to date. There are other anti-PD-1 antibodies that are currently being investigated. For example, pembrolizumab in a keynote study, nivolumab, then an anti-PD-L1 atezolizumab. So I anticipate a lot of these may potentially replicate what we've seen with cemiplimab. So I don't think this is going to be one, that's my personal opinion, I don't think it's going to be only one drug that will eventually be effective in this disease. I think we'll have a cadre of drugs targeting the same pathway, and we will just need to figure out what our personal preferences are in terms of how we are going to use these drugs. In terms of very early data with pembrolizumab, a lot of this was presented at ASCO 2018, and showing some very, very similar response rates, all ranging from 40 to 60%. But again, small numbers, small cohorts of patients.